Difficult symptoms during long-term treatment for breast cancer can have a dramatic impact on women's lives, with research showing up to 50% of patients opting to discontinue treatment due to unpleasant side effects. Today, we'll be discussing the difficulties arising for both patients and professionals. To get a deeper understanding of the nuances involved for those experiencing side effects, I participated in a roundtable discussion with breast cancer specialists. So what are the symptom side effects for women on endocrine treatment for breast cancer?
So some ladies are on these medications and they don't get any side effects at all, but a significant number of women do. These range from typical menopausal type symptoms, like vasomotor symptoms, so your hot sweats and night sweats. They go on to have other things such as, trouble with fatigue, brain fog. You can get trouble with vaginal dryness, other urogenital symptoms that you can just generally with the menopause. Hair, some people report kind of hair thinning. And probably the big things mainly with the aromatase inhibitors, which is your letrozole and anastrozole and exemestane, are joint pains and arthralgia. And this leads to a lot of problems and a lot of probably people seeking your further advice, the GP surgery and also the breast care teams with problems.
So, why is it important that women actually adhere to endocrine treatment?
Well, endocrine therapy is a very important treatment for women with hormonally driven breast cancer. It reduces the risk of recurrence and improves outcomes by about 30 to 40%. But we also know that women who don't complete their course of treatment have a higher risk of their cancer coming back and will then have reduced survival because of that.
As a GP, you mentioned I have patients coming to see me with side effects. We use HRT in general practice to manage menopausal type symptoms. Is it ever suitable to use HRT for a patient diagnosed with breast cancer?
I think it's like everything in life, you can never say never. However, kind of international and national guidelines at the moment are to avoid HRT in women with a personal history of breast cancer. Now, the caveat to that it says in exceptional circumstances it may be possible, and I think in exceptional circumstances means that primary care shouldn't be left alone to make those decisions with patients. We should be asking for advice and talking and communicating with secondary care. The breast cancer clinics out there are there for that advice, and I think to take that advice is really important.
And would you say that's the same with topical vaginal estrogens as well?
I think, again, there's no evidence to say it's safe to use that. I think it's a balance of knowing how difficult that symptom is for that patient, because if you can provide some symptom relief and that means they can continue on their endocrine therapy for a longer length of time, it's about a balance of those two risks. There are vaginal lubricants and vaginal moisturisers that can be used that don't have oestrogen in it, and there are certain vaginal estrogens that can be used with a really low dose of oestrogen that might be beneficial.
And in general, we were much worried about women on tamoxifen using topical estrogens because tamoxifen works by blocking estrogen receptors, whereas the aromatase inhibitors, they work by reducing the postmenopausal levels of estrogen to a very low level. Now, and so it's got to be balanced between the issues the patient has with their symptoms and those potential concerns, but that should be planned in conjunction with specialist care.
To truly understand the impact on patients' lives, I spoke to Julia. After starting letrozole following surgery and chemotherapy for breast cancer, Julia began experiencing some side effects that have affected her quality of life.
So I've had 2 separate lots of breast cancer, and then I was told that there was a high probability that I had metastatic disease in my spine. So I was transferred onto CDK inhibitors, which was palbociclib. I chose palbociclib, and it came with letrozole.
Do you experience any side effects? And I know that's probably quite difficult because you're on more than one agent. What side effects are you experiencing from the treatment now, a few years on?
Probably the biggest thing for me is tendinitis, the way that my muscles, my tendons are now compared to what they were before. I do walk a fair bit, so I'm active and I do Tai Chi, but the pain has been bad on both shoulders and it really limits my ability to do basic dressing tasks, washing myself. Can't do anything that involves putting my hands around my back at all. Probably the only other thing is I am less sure of myself than I was before. I can't remember and I have like brain fog. So things that would be really easy to have done at one point, I cannot multitask. It's one thing, do that. And sometimes I can look at a simple equation and just think, oh, can't do that at all. So it's mainly the tendinitis, it's the physical, practical things that bother me most.
And it does sound like it does have a big effect on your kind of quality of life. And as you say, you have to adapt. What support was offered by your medical team, and what were you told at the beginning about potential side effects?
Well, they tell you to do exercises. There's only maybe one day a month I don't do those every single morning, and I added to it the lymphedema drainage exercises. So that's a routine I have every single morning, which helps. Yeah. So I knew what to expect in terms of keeping mobile. So if I didn't do that, I think I'd be a lot worse.
Yeah.
When it became a problem, I did go. I saw the breast care physio. Yeah. And she was excellent. She got me to do lots of exercises.
So why did you continue with the letrozole? Because you said off camera, which I thought was really nice. You said that did it much nicer than I did. What did your oncologist? How did she describe your condition, the breast cancer diagnosis?
When they finally decided it was metastatic, and that's happened quite early on in my journey of the left side, my doctor said to me, just think of it as another chronic disease. She said, and if the current drug meds don't work, and they'll probably stop at some point, we'll just throw something else at it. So just it's chronic, you'll live with it. Yeah. And I thought that was brilliant.
Yeah. If you had known that it would have affected you how it has done, do you wish you'd known earlier? Would you have taken the drug?
With the exception of the shoulders and the tendinitis, it's not been as bad as I thought it would be, possibly because I've gone through the menopause already, and actually I had an easy ride. So the letrozole hasn't given me the worst of the kind of hot flushes. I never had that anyway.
Yeah. How was your experience in primary care?
I think it was fabulous. I think everyone I've contacted has always tried to help me deal with the problems I've got. I really, really cannot praise people enough. From the breast care physios, the MSK physio at the GP, and the GPs behind that decision. Yeah. But I just think the teams, everyone in the NHS has always been on my side.
With some evidence to suggest HRT may increase the risk of disease recurrence, what else is available for patients? There are some well-evidenced non-pharmacological options, which include keeping the body temperature more stable by wearing layers that can easily be added or removed, cooling pillows and/or cold water bottles. CBT, cognitive behavioural therapy, has been proved to be beneficial. This includes self-help books and formal courses, some of which are NICE and the British Menopause Society approved. Basic lifestyle advice about exercise and weight management can help with the loss of symptoms. Avoiding phytoestrogens such as soy, black cohosh, sage, as well as evening primrose oil and vitamin E, which have limited evidence that they are actually effective. Pharmacological support also includes SSRIs and SNRIs, for example, venlafaxine, paroxetine and fluoxetine. Oxybutynin is now thought to be beneficial. Clonidine, gabapentin and pregabalin can also be used. But what about the treatment itself?
You could always change the endocrine therapy that they're on. If they're not getting on with one of the medications, it's swapping it to something else, and some are more closely related than others. And I think it's probably worth just mentioning we've mainly been focusing on women, but we obviously put men on endocrine therapy after diagnosis of male breast cancer too. We tend to use mainly tamoxifen in the men, and they can get the side effects as well, and sometimes they want to come off the tablets just because of that. We're a bit more restricted in terms of swapping medications, because for men there's not good evidence that aromatase inhibitors are going to as good as tamoxifen. Even for the male breast cancer patients, there is something that we could look into for them.
What tools are there to support primary care? Having a conversation with the patient about their individual risk and ensuring that there is good compliance with the medication.
we would suggest that those discussions take place within secondary care. So if a patient is struggling with the management of their menopausal symptoms and they're wondering whether it's for them it's worth the risk-benefit ratio of the drugs, then I would generally encourage GPs to refer back into secondary care for those conversations.
If we need a bit of support and advice in primary care, or we want to signpost a patient somewhere, where would you suggest we contact?
So we're obviously putting these educational packages together. We've got this video we're doing, but there's also going to be an online educational kind of session that kind of primary care can access, that hopefully gives us a bit more in depth to what we've been able to discuss today. GM Cancer website's got a really good amount of stuff on, especially around endocrine therapy, and then kind of nationally charity-wise is the Breast Cancer Now Macmillan. Have kind of great resources, and the patients hopefully have already kind of had some kind of support through things like the Maggie Centre locally during their actual diagnosis, that are kind of great local kind of ways that they can kind of go in contact, and they could always ring their breast care nurses. So the patients need to remember that their breast care nurse is still their breast care nurse even after they're outside that initial phase of their treatment.
From a primary care and a secondary care perspective, and it's really important to ensure that patients have a good quality of life after a breast cancer diagnosis. But it's also important to know what risks there are out there and what's important to consider when making these decisions about HRT and menopausal symptoms.
It is important for primary care to know what's available for those patients experiencing symptoms related to endocrine treatments. Ensuring open lines of communication between primary and secondary services means specialist teams can be contacted for additional support. Being honest with patients during their initial consultation and making them aware of potential side effects could fundamentally improve compliance. By listening to the patient, understanding their individual needs, decisions can be made alongside colleagues from secondary and tertiary care. As always, the balance of risk of recurrence and benefit to quality of life needs to be thought through carefully and managed appropriately.